Cool. We got a couple people coming on here. Feel free to introduce yourself when you come on, just so we know who's all on board here. I see Dan's here again. Glad to have you back here again, Dan. One other new one that I don't recognize. Feel free to introduce yourself. You can come on in, unmute, and introduce yourself, or you can just type in the chat, whatever works good for you. Today's topic, we're going to be talking about shoulder pain, but as it relates to the C-spine.
Especially with ADHD, they're on the edge when they have this concussion too, without free nerve ending. So you have to be a little bit more careful. If, thank God, not too many do, but you could see cervical radiculopathy with head trauma.
Screen real quick, yeah. Just to keep the background noise a little bit softer. If you want to come on in, it's more than welcome, but there's some background noise too. So if you can unmute yourself and come on in and introduce yourself, ask a question, feel free to do that. But unless you're communicating to the conversation, we'll keep it on mute. That way we keep the environment a little bit easier to listen to. But appreciate you joining in. And like we said, we're going to be getting into some T-spine assessments as it relates to some different scenarios. Clients can be anything related to sports or just general orthopedics. We'll get into some things here. If you got certain clients in mind or a certain population that you treat a lot and would like to talk more about, feel free to type in the chat or come on in and ask. But we'll get rolling. I think the big thing first, Eric, to just start talking about is, what's the importance, obviously, of starting to address the T-spine as it relates to shoulder. Because someone could be coming in with shoulder pain, but not everybody necessarily looks at T-spine and how it could be contributing to the issue. So what's some things that you think are contributing factors to shoulder pain as it relates to thoracic rotation?
So I would definitely say a lot of times if they have shoulder pain, there's usually a shoulder component to it, but I think thoracic mobility is huge and can be definitely underlooked. Or overlooked, I should say. So really what you're looking for is just to see how mobile they are. You're not worried about stability or anything like that. You're just looking to see how their mobility is with extension, flexion, and then notably rotation. So definitely, like, you look at your overhead athletes, any baseball pitcher, let's take a right-handed baseball pitcher, volleyball player, quarterback, you need right thoracic rotation. If you don't have it, you're going to get the motion from somewhere. So your shoulder's just going to have to have additional movement that it doesn't want. And then you're going to end up with too much going on with the shoulder.
Right. We were just talking a little bit about this before the chat started and everybody started coming on. But like thoracic extension's a big one. If we talk about dips, in particular, this was the case we were discussing. Thoracic extension is going to be important, as well as shoulder extension. But if you're not able to get a certain position from the T-spine, then the shoulder's got to pick up some of that extra motion there, so it can be placing extra stress on top of the shoulder. Obviously, the rotational sports, same kind of thing. You got your lay back position with throwing. Tennis, really any type of rotational athlete, if you're coming through the T-spine and you're not rotating through, then in order to create some of that torque and some of that power, you're going to be picking up some of that extra motion in the shoulder. Particularly the anterior shoulder, I'd say, gets a lot of the brunt of it. So rotational sports thing, again, kind of coming back through. If you're having to extend, externally rotate the shoulder, you're putting more stress on the anterior structures there. If you can't get that rotation component through the T-spine. Same thing with the dip example that we gave there too, is if you can't extend through the T-spine, more pressure through the anterior shoulder as you're getting down into that dip position there too. So all things to think about. Obviously there's coupled motions involved in the shoulder too. It's not necessarily just like with the dip aspect, again, there's internal rotation that's important as well. But the T-spine is more or less a foundation, the trunk that the branches come off of, and it's a low-hanging fruit that a lot of people fail to kind of address too. So when we're looking at it, what's some things do you start looking at first, Eric? You mentioned flexion, extension, and then rotation. What are some ways that you do that? You do that in standing and then get them seated quadruped, something like that?
Yeah, I'll start out standing and then just have them do arms up extension. And you're not just looking to see, can they extend their upper body back? You're looking to see, and again, it's kind of a general gross assessment. You're looking to see segmental mobility. So ideally they should have a little bit of almost like a reverse C whenever they extend back. Do they have segment by segment? Does it look like it's kind of a congruent or a nice, whatever that would be, concavity? Yeah. Or are they, yeah, I get those mixed up. Or is it where you're getting movement here, movement, no movement, and then there's a hinging? So same thing with flexion. Is it super flat? Is it a nice C curve like a candy cane? And then from there, honestly, you can do rotation, but I like to, after we're looking at those, you need to remove the segments above and below. So take the shoulders out of play, take the hips and lower back out of play, and you'll do the lumbar locked. So you basically go quadruped, then rock back, so that way your butt is hitting your heels, and you can do arm behind the back, and you're just rotating up like you're in a tunnel. So it basically takes the thoracic spine, makes it the kind of the center of movement, and then you're seeing how much they rotate. So you're looking for 45 to 50 degrees there to kind of break that diagonal plane, and you're looking to see how their motion is.
Yeah. With the hinges, so going back to the extension, arms overhead, extending, I know where I'll commonly see people hinging right at like the TL, thoracic lumbar, T12, thoracic lumbar junction. Is that pretty common? What you notice too is someone just hinging at that point and getting all their segmental mobility right there.
Yeah, oh, that's huge, especially a lot of like your lax, even like, well, it's for a different reason, but like your younger females, whether it's a gymnast, CrossFit athlete, anybody overhead, thoracic spine stays straight, they just hinge at the thoracolumbar junction, or even like your older gentlemen who have poor thoracic mobility and are pressing weight overhead, they can't extend their upper back, so then they just hinge right through there. Then they have subsequent low back pain.
Yeah, and you can also kind of see that too if you're having a hard time seeing it from the extension. If you just look at the front side, you'll see the anterior ribs from the anterior view. The lower ribs start to really flare out in front, and they can't kind of keep that torso position there. Or if you even just lay them on the table, you just already notice them already in extended position there at the anterior lower ribs laying flat on the table. You see the T12 just kind of popping up with the ribs there laying flat on the table. And then if you put them in hook lying, sometimes they reverse out of that, but just the more extended you create them, the more they want to bias themselves into that position. Do you feel like you get a lot out of that test? So just the standing thoracic extension, because there's a lot of things happening there. And not too many people perform it well. Do you feel like you get a lot of useful information from doing that?
I would say, and I don't have any research to quote this, just a standing extension test, I would say it has a high sensitivity, but a low specificity. So if somebody performs that really well and they have like fantastic, that reverse C, there's a chance, I mean, the likelihood is that they don't have an issue with extension or with thoracic mobility necessarily. But if there's anything wrong with it and it doesn't look perfect, then I'll take them into like lumbar locked rotation. But to be honest, just like clinically, even if somebody performs that well, I almost always have them still go hands and knees and then do a thoracic rotation. You'd be surprised sometimes somebody looks pretty decent, and then they're still not having full mobility. So,
yeah. Dan asks if you add weight to the hands, so like a gravity ball or possibly like a dumbbell, just to assist with that. Would you notice increased range of motion? I would say you probably would notice increased motion, but you'd probably notice an increase in compensation at that point in time too.
Yeah, typically, like we've talked, if you add weight to anything, it'll bring out your deficits even greater. So if you're hinging at the thoracolumbar junction some, add weight overhead and like a medicine ball and have them go back, then you're probably really it's gonna exacerbate that and you'll really see it.
Yeah. The other thing too, because I'll see this performed sometimes, is someone feels like, so they know thoracic extension is limited, but and they use what you just described almost as a corrective. So they notice their standing extension is limited, so then they put a weight or just like a medicine ball and have them actually, extend overhead, or, put them in like a running position or split squat position and then have them extend overhead. So one leg's forward, one leg's back, to get a little bit of hip extension on that back leg too. I don't know if I'm really in favor of that though, just because if someone can't perform it competently in standing unloaded, more than likely, like we talked, when you add load to it, you're just going to make the compensatory action greater. And then furthermore, when you put a med ball in someone's hand, you're connecting the right and left side too. So it's similar to using like a barbell in that fashion, where it's going to restrict some motion as well. So by having things glued together, it's probably going to lead to some more compensatory action. You'll probably notice the lower ribs, anterior ribs flaring even more so when they do something like that. And just they end up getting a lot of a lumbar extension. With that, they may get some T-spine extension, but it's not necessarily done competently.
Yeah, you're looking to reduce components and narrow down the thoracic spine. So the more components you add in, the more things that can go wrong. You want to narrow down thoracic spine. Like I said, and I haven't found a better test than the lumbar locked, where you're back there rotating. It tells a lot, and people will be able to report that. Like, I'm just stuck, I can't go anywhere. So you're assessing rotation technically with that test, but it also gives you a good idea. Those facets, if they can't rotate, a lot of times they also can't extend back on one another. So it gives you a good idea if they need extension work. We can talk about like how to go about that, obviously, but for assessment, they're having trouble with extension, rotation, things like that.
Yeah. Real quick. So Dan mentioned in the chat there that, load bearing is presumably not always the way to kind of tell not always be able to tell the way of, or the origin of the dysfunction, because there's a lot of compensatory action. So similar to what we were talking last week with the shoulder, and just kind of using position to allow someone to succeed, kind of the same concept here is, and that goes into the lines of a lot of the educational programs out there that talk about, neurodevelopmental sequences, or, as, the baby develops, how they progress from, say supine to quadruped to eventually standing. Just kind of going through those different positions that lead to various amounts of different control. I think that's a lot what we'll be talking about here, is finding the position that is the most challenging for them, but they can still perform it competently and perform it well. So yeah, with rotation, the lumbar lock position, I'm assuming you're getting them on hands and knees. They're kind of sinking their butt back down to their thighs and or to their ankles. And then do you put the elbow kind of in between the two knees, or do you keep it out wide? You put the hand into external rotation or internal? Do you bias anything like that?
I put it into internal rotation, but it doesn't have to be excessive. I usually just say like loop onto your back belt, or like in your back right pocket if it's your right hand. So I usually go to internal rotation. I have had some that I'll do. I just did this on Saturday across the chest. Otherwise, it hurts too much to go into that internal rotation. So, I mean, I could always demonstrate it right now if you want me to turn the computer around. But
yeah, I think most people got what you're
yeah. So
if anybody doesn't know what we're talking about, just put it in the chat, and then we'll go over it. But yeah, I think that's an important aspect, because a lot of times you're seeing someone who's in pain, right? So a lot of times these positions are provocative. So something that is very simple, just keeping it at the chest, allows you to still look at the T-spine there. And you're looking for 45 degrees. Is there kind of markers that you're looking at the body just to kind of get a good concept of how far they're turning?
Yeah, 45 to 50 degrees, really. If somebody can go 50 on one side, I rarely see this, and they could go maybe 70 on another, like a gross difference. They clear both sides. Technically they clear, but one is way more than the other. I'll still take a look at it just because it's asymmetrical, but I don't know if there's really an issue there, to be honest.
Yeah.
It would be my first go-to. If they clear 45 to 50, I'm going on to something else usually.
Yeah. There are some scenarios where you'll see some like odd things when someone tries to rotate, where it just doesn't look natural. You'll see, so when you rotate, so if you're rotating to the left, the ribs on the left-hand side are going to be externally rotating. to allow for you to turn to the left, and the ribs on the right-hand side are going to be internally rotating to push you that way, push the sternum that way. Kind of P&F patterns, think about that too, is if you're driving internal rotation on one side, so here it's going to push my sternum to the left. So if internal rotation pushes you towards the left side, internal rotation pushes you in the opposite direction. External rotation kind of drives you to that same side unilateral position. And sometimes you'll see some funky things with individuals who have kind of like these various different rib cage presentations. So someone who is very, very wide at the rib cage, a lot of times you see that flaring kind of really start to increase. And sometimes I don't know if there's any way to really quantify this, but sometimes I feel like they're getting a lot more of that motion from rib action than necessarily getting true T-spine action. There's some other things that I look at personally at the rib cage more to kind of look at that to deviate them more on supine on their back and kind of holding the rib cage down and looking at shoulder motion and how that may affect it. But something to consider when you're looking at the T-spine rotation is just what's the ribs doing in conjunction with the rotation aspect of the thoracic spine. So just not necessarily always where you're getting the, like we talked with the extension, kind of where you're getting those folding lines. So there's not that universal curvature. Same thing with the T-spine rotation. If you're noticing all the rotation just at the lower rib cage, you know, they may not be getting a lot of upper T-spine rotation from it too. So a lot of times you'll see kind of the lower ribs just turn with it into external rotation, but you don't see kind of the upper ribs rotate and the shoulder come around with it too, if that makes sense.
Yep.
So looking at it, addressing it, what are certain ways that you look at addressing it first, Eric? I think we address it similarly, but also have some differences, I think, from what we've talked about before in the past.
Yeah, I'm going to touch on it real briefly from a manual therapy standpoint. So if they don't have pain associated with it, if they have shoulder pain and thoracic pain, you may do, for example, a lot of times I'll do like a manipulation. So I'll manipulate thoracic everywhere from like TLJ up to like T1. Again, that is not a long-term fix. That is if they have pain and I'm looking to help reduce pain, maybe get something moving a little bit, hypothetically, depending on what you believe the manipulation does. And then soft tissue work, I doubt the soft tissue work is really restricting a ton of their range of motion. So it's more joint related, typically, in my opinion. And you may disagree with that, but I feel like rarely is like a tight paraspinal going to limit your thoracic rotation by 40 degrees. So maybe more manipulation, and then I'll go and give them self-correctives.
Okay.
So we can discuss a couple of those just to give the concept, but if you want to discuss anything from there.
Yeah, well, let's hold off a little bit on the correctives, just a little bit more. So with the manipulations and kind of when you decide to go to them or not, are you using sensation at all to drive when someone may be appropriate for a manipulation at all, or just pain? So say someone rotates and they say they get like a pinching or a locking type sensation with the rotation. Is that something that you feel would warrant a manipulation in your case there?
Yeah, you led right into that. So, I mean, could you be getting something with a facet doesn't want to extend right or rotate right, one over the other? Plus, manipulation takes about 20 seconds to set up and complete. So I just feel like it's a good retest. If they have an issue there and you perform manipulation, did it clear that up? Did it not? If it didn't, then I doubt that it's going to clear it up the next time if you think it's truly a joint issue. Yeah, so it's just a nice quick way to do it. You can also do like prone PA mobs, something like that, and see if for 30 seconds, if you do those, does it improve that sensation? Mm-hmm.
And then when you said tight paraspinals wouldn't be limiting thoracic rotation, I would agree with that to some extent. So why is a paraspinal tight or concentrically oriented? Is probably because someone's extended. if they're in that orientation to begin with. So there's kind of your coupled motion again too. Is paraspinal is probably not necessarily the reason. It could, well, depending on what your thought is, you know, maybe they're always using their paraspinals for whatever task they're trying to complete, say an overhead lift. So they're extending at their T-spine, they're using their paraspinals to extend at their T-spine. Maybe that's not the fact, but that's not, it's kind of neither here or there. That's not what we're looking at addressing. We're looking at trying to get them out of extension, out of that probably anterior rib cage flare position, so that you're not taking up mobility in one plane, which is restricting your motion in another plane. So if you, with coupled motion, I mean, if you're extending, it's going to limit the amount that you're able to rotate. In general, with more flexion-based positions, you're able to rotate a little bit more with that positioning, just due to the orientation of the facet joints. So someone who's always extended, they're going to get into that lock position a lot sooner. And just think about your manipulation. So the closed pack position that you put someone in to get the manipulation is always, you're taking up segments in one plane of motion, and then you take it up in another position to get end range of motion, and then you apply your manipulation. You can correct me if I'm wrong there, but so there's different planes of motion, and different positions are going to impact someone's ability to rotate side to side, whether it's more extension based or flexion based too, if that makes a sense there.
Yeah, Dan asked a good question, and this isn't just for the thoracic spine, but this is just manual therapy in general. And this is kind of one that we hear a lot, as far as whether it's like a chiropractor, PT, whoever does, even whether it's joint work, manipulation, or soft tissue work. He asked as far as like holding or how does it stick. That's a huge debate anyway. I would just look at it as, again, I think, Greg, you're kind of similar with me. Doing manual therapy or manipulation gives you a window of opportunity where they now have more improved free movement with less of a pinching sensation, let's say. Now is when they need to do more lasting changes, or create lasting changes, which is them doing active movement, true mobility, strengthening through a new improved range of motion. You could manipulate day after day after day. And if somebody doesn't, I mean, movement is life. So you have to move to have it, quote unquote, stick.
Yeah. And that's where the test retest model kind of comes into play. Is if you test something, you see a change, you know it's affecting that individual. So then you have reason or warrant to kind of continue it. But at some point in time, they need to be able to come into your office without having to get that type of manipulation. Now, depending on the task, whatever they're doing in life, you know, occasionally maybe they do have to come back to you and see you because, you know, they're an athlete, they're pushing their limits a little bit, so they need some of these type of interventions on occasion because they are pushing their limits, they're taxing their body to a point, which this is another debate, maybe it'd be a good topic for some other time too. But if you talk about a spectrum of wellness and sickness, performance doesn't necessarily lie on that spectrum. Performance is outside here too. So as you move closer towards wellness, at some point in time, the further you move towards performance, you're kind of moving away from wellness at some point in time too. So at certain times, you do need some of these adjunct treatments to just help keep someone performing at a high level because that is their goal. We got off topic there big time, but
that's a good topic. Yeah, that's a whole nother rabbit hole to go down. Yeah, passive treatments, and I'm all about manual therapy. I love it, but it is a passive treatment. It gives me a chance to give the patient or athlete a chance to then do things long-term, like strengthening mobility, not just them laying on a table and me manipulating them. Yeah. So
Dan brings up the question. This is a term that gets thrown out there a lot, which is function. So I worked for a company initially out of PT school it was Gary Gray Physical Therapy, and arguably the most influential person who termed functional exercise. Someone could argue that too, but you know, he really brought it to light for a lot of people. But I think it's taken a way bigger all-inclusive term than what it was really intended for. So functional, what is functional? People always say it has to be an exercise, but function is what the individual is trying to do. So if they're trying to play football, function is football. If they can't play football and a manipulation all of a sudden allows them to play football for whatever reason, just taking that n=1 scenario, a manipulation was functional because you just got them to do their function. So anything can be functional. So I use the term loosely, but when people say something is functional and something else is functional, I think you got to kind of look back at what are they trying to do, and is it progressing them towards that? Then, in my opinion, it's functional.
That's a good example. Yeah.
Back on the topic of T-spine rotation, shoulder pain. Rotation can also influence scap position too. So, like I mentioned, if you're rotating to the left, your lower ribs and really your ribs are externally rotating. You're rotating ipsilaterally to the side that's externally rotating. The scap does the same thing too. So, or at least ideally, it doesn't necessarily mean that this happens all the time. But if someone is rotating to the left, you're getting scapular retraction or external rotation of the scapula. So if the scap's sitting here and you're rotating to the left, then you're getting this external rotation of the scapula that happens here. Same thing with the ribs. You're rotating here, so your ribs are ERing ipsilaterally. Your scap is externally rotating ipsilaterally as well. And on the opposite side, to kind of come through, your scap is internally rotating and the rib cage is internally rotating there as well. So depending on how someone's scapular positions may be, I do use static assessments to look at that sometimes. A certain rotational movement with a reach or a retraction may be warranted too, just to help kind of facilitate the scapular position that you're striving for. So in the case of someone who's very, very retracted at the scaps, and maybe they can't rotate well, if you introduce a reach, you're protracting, internally rotating the scap some to kind of move it around the rib cage, and yet you're still facilitating a rotation component. So you're kind of killing two birds with one stone at that point in time, addressing multiple things at once. So definitely adds to the complexity of the whole assessment, treatment situation, but it's something to kind of start considering too as you look at rotational movements and how the scap relates to that as well. So
yeah, I know you look at that.
Go ahead.
I was just gonna say, you look at that and address that really well, more than I do. I don't look at it a ton, not because it doesn't work, just because I happen to not look at it a ton. Different folks, different things, but
I think you actually address it more so than you think. So I mean, if you just go, a lot of times the assessment is the treatment. So if you go lumbar lock position, and if you got other ways of treating this, we'll bring it up too. But so if you go lumbar lock position and someone has a reduction in rotation, let's go to the left again, and you want to try to improve that, you could use some type of assist with that movement, whether it's putting a band around the shoulder to kind of help bring them back into external rotation, trunk rotation to the left. Or you could use your hands to kind of help facilitate them through a larger range of motion. Again, active assistive, you can usually get a little bit further than active. So eventually you try to take some of that assist away. So when you're doing that, you can also be cueing things in that same position. So if I'm trying to rotate to the left, if I cue that pushing into the ground with the right arm there, that may clear up some rotation just by having them push their whole, whether down their forearms, as they push the whole forearm into the wall or the floor, or if they're in quadruped, you push the hand down into the floor. and you get that reach component with it too. So that reach could lead to more thoracic movement. Something else I noticed too is if you just tell someone to turn their head and look towards where they're moving, obviously that usually gets a little bit more motion too, because where you're going to go where you look. So if you turn your eyes, turn your head towards that way, oftentimes it'll prove some motion too. So sometimes you got to be a little bit careful, as if you may deem that there is a problem in the area, and it may not actually be a mobility issue. It may just be how they're performing the task. Because if you can clear it up with just cues, they probably don't have a mobility issue. It's just a matter of how they coordinate the task. So that's more of a motor learning type of a thing that's going on there.
Yeah, which is figuring out if they have like a motor control issue, like you just mentioned, or if it's true immobility. So yeah, like if you try to bring them through, if you have them locked down and lumbar locked and you try to rotate them, and no matter what you do, they are stuck. That is not a motor control. They can't go there.
Right. I don't know if you have like any order that you usually go to. Usually when I'm looking at that, they're already performing the test right there. So I usually just try to cue them a little bit differently and just see if they improve. And if they don't improve, then I give them the assist and see if they improve. And if they don't improve, then obviously now we have notion that there's some mobility issues. And if they do improve, I think that using that order kind of teases things out pretty quickly for you.
Yeah, I agree. So can they do it on their own? Can they do it with just like verbal cues internally? Can they start to coordinate that movement? And then if not, can I take them through there physically? So then, yes, it would be a true mobility issue. It is not just like completing the task issue.
Right. Dan asked let me read this real quick. Are some athletes prone to recover differently or compensate differently than others? Essentially, and just asking about different sports, so swimming, baseball, gymnasts, in regards to the thoracic immobilities. So if we discuss some tendencies here, if we go with baseball players, so right-handed or left-handed is going to mean a big difference between the athlete, how they would compensate through the thoracic spine. And that compensation may not necessarily be a bad thing either, because it may make them, what's great is having that asymmetry there. So just in some instances, so right-handed thrower, you would assume they probably have a little bit more right thoracic rotation to get some of that layback. And Eric, you're the baseball guy, so you can correct me if I'm wrong here with that, but that's what I would kind of assume. Now they may not have it, and if they don't have it, then that's probably something that would be useful to work on for performance. But if they do have a lot there, maybe they don't have a lot to the left. And if they've picked up a lot to the right, it's probably to some extent the reason why the left has become limited is because they're always turning to the right. So do you really want to take that away from someone? I would say you probably more want to manage it with someone as opposed to trying to truly correct that and create a symmetry with them.
So I actually usually demonstrate the lumbar locked rotation position. I'm a right-handed thrower I played baseball in high school and college. I have fantastic right rotation. I have virtually no left rotation. So yeah, very, very similar to what you alluded to right there. So I'll even demonstrate how I'm asymmetrical. But again, if I don't present with shoulder pain, if it's not an issue and I'm throwing, then why correct it? Because there's likely to figure out why the reason is for that. So yeah, you make an excellent point there.
Yeah, and the same kind of when I was doing a rotation with Joe Heiler back just out of PT school. He told me about when he was going over all this. He told me about a time when he was over at Athletes Performance, now 𝐋𝐄𝐓'𝐒, and there's some baseball pitchers at the area, and it was crazy how much limited they were to one side compared to the other. But again, there's probably a fine line that you walk there where it's more of a managing situation, because again, you're not looking at health and wellness necessarily. You're looking more towards performance, so you're moving away from wellness to some extent. So it's more of a managing situation that happens then. If we go to, so swimmers isn't something that I personally have a ton of. I'm a terrible swimmer. I don't have a ton of knowledge working with a lot of swimmers. I don't know if you do, Eric, but this is just what I would think we would see. You see a lot of hypermobility at the shoulder is something that you hear a lot about, but it doesn't necessarily mean that they may rotate well, because if they're swimming in just your normal strokes, the different strokes probably influence this to a certain degree, but you're using both sides evenly. So they probably have some hypermobility through the shoulder, which is common usually in swimmers, but their T-spine doesn't necessarily have to follow with that. The other component with that is they're going through periods of times where they're holding their breath, and how they work their breath cycles probably has a big influence of how well they're able to rotate. I don't know the coaching behind breath cycles to swim appropriate, so I can't speak to that end. But if you are holding your breath, you're stuck in inhalation. Inhalation is extension based, and we already talked how those coupled motions can be reducing some rotation. So to a certain extent, if someone is maybe they even if you talk to their coach, maybe they talk about how they struggle with timing their breath cycles up appropriately. Maybe that influences it too. But the air volume in the lungs is going to impact thoracic rotation. So if someone has imagine just kind of two beach balls on either side of your armpits, or two balloons on either side of your armpit. If you're trying to side bend, air volume is going to restrict your ability to side bend in one direction. Until you get that air volume out, then all of a sudden you can start side bending a lot more. So that's something with swimming to consider. Again, I don't have a ton of background with those athletes. I don't know if you have anything to add there.
No, I don't have a ton with that. I know in college, if you want to see unathletic people, put 25 college baseball players in a pool for conditioning and watching them. That's a big joke. But the only thing I would allude to with that is a lot of times, and I do not know the strokes well, I'm not a swimming expert. Freestyle, I believe a lot of times, they're usually taking their breath out of the water from the same side. So for example, they may rotate their head to the right out of the water. So they may also then just naturally have increased rotation to one side based off their preference of which side their head comes out of the water.
Yeah, I like that. I like that.
That is the only thing that I would know to look for as far as asymmetries. The other strokes, I believe, are mostly symmetrical. So yeah, I can't. That's about all I can speak of with swimming.
Yeah, I didn't think about that. Usually they are always going to one side to get their breath. Usually, yeah. Okay.
Yep.
And then gymnasts, those are usually a whole different equation, where that's usually just someone who has hypermobility to the max, shoulder, T-spine, hips, everywhere, and that is a little bit different scenario, where now we're probably not trying to increase range of motion. We're probably more just trying to work on controlling that range of motion, or using it more efficiently, or distributing it more efficiently. Because you could still see, similar to the back bends is very, very common with gymnasts. If you do your lumbar extension, global spinal extension pattern, you can still see a lot of hinging going on with those clients at one particular segment. So say the TL junction again too, just because they have a lot of mobility doesn't mean that they distribute pressure well across the whole spine.
Yeah, and they may not be using that mobility appropriately through their entire range. Did you want to, Greg? Did you want to touch on some of like how to like, if you had to pick your top 3 ways to address thoracic mobility, what you would go with?
Yeah, that'd probably be a good way to kind of close out today. Yeah, so top 3 ways. First thing, the lumbar lock position is probably my favorite place to kind of work on that. So that's probably the most common one that I use. And then how I cue the reach, how I cue the breath, and how I cue them looking to the side is all very patient client dependent. But that's all something that I'm trying to kind of incorporate with that rotation, is just those specific nuances of it. If they are struggling with it and active assistive motion helps them, then I usually put a band around their shoulder to help them and attach it to like a squat rack or something on the opposite side, so it helps them kind of rotate up through that. And then I'll actually have them hold at that top position where you've lost some of the assistance from the band, because the band's going to have the most assistance down at the starting point, and then when you rotate with the band, it's going to take away some of its assistance. So it gets you to the top range of motion. Then I'll usually have them isometrically hold there and go through some breath cycles. That I would say is probably my favorite way of addressing it. The other way I like addressing it is with a split squat and a cable pull. So if you put someone into a lunge position, isometrically hold that position, kind of get their, this is again, if they can kind of control their segments well, and they're not going into hyperextension or anything of that nature. Their torso looks in a nice vertical fashion. Getting them to kind of pull and incorporate that with breath cycle too. So kind of rotating with inhales and exhales, and even getting the other arm to kind of reach forward as you're pulling with the other opposite arm. Those are probably my two favorite ways. And then the other third one that I give out, and this is kind of a common one just with athletes with their warm-ups, is a lot of people perform the Spider-Man or world's greatest stretch, kind of whatever you've heard it called, where they're in push-up position, then they bring one foot up to the side of their arms, and then they kind of rotate the hand up towards the ceiling. Great activity, but a lot of times when you watch an athlete perform that, they may not actually be getting T-spine rotation, they just may be getting shoulder abduction, or they may be so limited in that fashion that they just can't rotate whatsoever. So sometimes putting the back knee down on the ground allows them to rotate a little bit further as opposed to having it up in the air. Or same concept with the lumbar lock rotations. If you just get them to go through a full range of motion or what they have available to them, and then kind of breathe isometrically holding that position, usually through some breath cycles. On the exhales, you're able to rotate just a little bit further. So you can kind of gradually work a little bit further into that range of motion.
Nice.
What about you?
You stole my first one, the lumbar locked with the band assisted for rotation. Definitely go with that one. I work with a ton of like overhead lifters. So a big one that I'll do is everybody does it, but usually people do it wrong, the thoracic extension over a foam roller. So you just see people, they lay on the back on a foam roller. Pretty much usually what they're doing is their ribs in the bottom flare up, and they're just hinging at the thoracolumbar junction. So I'll just make sure that I cue to them, keep the ribs down, keep the stomach tight. And a lot of times if they can, I'll actually have them, I just did a video on this, I'll have them hold a kettlebell, nothing heavy, overhead. Works on some lat mobility too. And they'll actually control through that range of motion, going back overhead, getting motion really upper mid thoracic, and then take a breath while they're down there, get comfortable there for a second or two, isometric, and then come back up. So they may work through a couple different segments for 60 seconds total time, more done as like a warm up. But again, that's promoting more bilateral extension. But a lot of the people that I work with have bilateral extension issues or issues overhead.
I use that one a lot too. One modification that I tend to prefer and like to use with it is just getting the hamstrings involved with that. So if you put their feet up on a bench, dig their heels down, isometrically contract the hamstrings to posteriorly tilt the pelvis. That helps keep the lower ribs down too when you cue them, so that it really kind of takes them away from extension as it biases them a little bit more into that neutral position or even a little bit flexed position, and then have them control that position as they do the kettlebell pullover.
I've not done that, but I like that. I will make people do that now. The other one I do a fair amount would be if somebody's more like unilateral, has an issue with rotation, ipsilateral to one side there, I'll have them do your quadruped and you're parallel to a wall. You're almost doing, it's like kind of like a shoulder warm up, doing you're moving your hand around the wall, trying not to touch the wall. So I will cue them to push long through the arm that is on the ground away from the wall, and then work on rotation up and around, if that made any sense. So you're basically just doing a circle around the wall, and you're promoting thoracic rotation, pushing, and then rotating as you go up and around.
Yeah, if the wall's here, you're kind of coming through like that.
Yep,
like
that is it.
Backstroke almost of a swimmer there next to a wall, getting some T-spine rotation towards the wall.
Yep, and then I'll have them reverse it and go the opposite direction, then coming back. Work on controlling that. If they need to use the wall, I actually have them press on the wall and then take a few breaths to promote. It's more assisted then. They're getting assistance with rotation. So I'll do that one a fair amount. And then the one that you'd mentioned, I would say those are probably my top three.
Yeah. Real quick, the last question Dan had here. With working with CrossFitters, we're engaged in abrupt movements causing dislocation, hyperextensions. What are you noticing with CrossFitters? I would say from working with some too, I would say that extension bias is probably the most common. Someone lifting a lot of overhead or doing kipping pull-ups or even just general pull-ups, they tend to extend a lot at the back, which could be due to thoracic limitations or shoulder limitations. Just something you want to tease out there.
Yeah, I second that. A lot of times it is if their thoracic mobility can't go back there into extension, they're going to get the motion from somewhere, especially if there's momentum involved, like a kipping motion. So yeah, then it's just going to be all glenohumeral joint, and then it just gets excessive motion.
And you will see people who are limited in both thoracic and shoulder as well too. So
not to pick on them, but yeah, your 40, 50-year-old males, tight lats, tight teres, poor thoracic. So yeah, multiple components.
Okay. I think we'll round that out for today. What we're doing here now is we're trying to make it a little bit simpler for questions to kind of be cultivated, asked prior to the talk, so we can get more people's questions on here, more stimulation of conversation. So we're going to put some, it's kind of like a specific general topic for each month. So June, we're going to be still focusing on the shoulder. Shoulder will be the big concept. So anything that revolves around a shoulder, could be injury, could be performance related, could be sport related, could be thoracic spine like we did today as it relates to the shoulder. We're going to try to keep it along that theme moving forward for this month, and then next month we'll have a different theme as well too. So feel free to, again, message us with any questions you have beforehand. Feel free to submit your questions in the Facebook, email, on the website. We have a area where you can go in and submit your question as well too. So any way possible, get those questions in, and we'll keep answering them and keep these talks going. Thanks everyone for coming on.